All right, so welcome. Our Module 5 Zoom session for tonight. Dr. Turner is going to lead you through some conversations, some case study. We'll have time in breakout rooms. And this is, we'll spend a little more time in breakout rooms tonight because the feedback from last year for this session really, it was pretty clear that people wanted more time together in the breakout rooms to discuss things. So we will be doing that. We have a couple folks we're still waiting on, but we will get going. So I don't believe I have any announcements tonight. It was great seeing you all Friday. The posters were excellent. Everybody did a fantastic job. Thank you all for getting the electronic versions to me, and I'm going to make those all available to you very soon. Probably tomorrow. Actually, I'll get them into a shared folder and then share them with everyone. Other than that, just a reminder too, so with our Zoom sessions, with the registration links, I do send those out the week before as a reminder, but you can go into Canvas and register for all of the future Zoom sessions, at least through Module 9 and then eventually through the rest of them. The links are in Canvas already. So I know some of you discovered that, but just a reminder. So you can click on those and register for all of them ahead of time if you want, but I still send the email as a reminder. It helps me remember as well. So, okay, with that, Jane, I think I'll hand it over to you. Oh,
Okay.
last thing. So I sent a link to you all with the trainee bio page. Please be sure to look at it if you want to change your picture or if there's anything in your bio that you notice may be wrong or you want to change, please just let me know. It's no trouble to change. I want to make sure it's accurate, but I think it looks really good. You're all very impressive. So, okay, that's all I have. So Jane, I will hand it over to you.
Okay, thank you. Yeah. Good evening, everybody. I hope everybody's had a chance to vote either ahead of time or today. We'll be watching for results at some point. Not sure when we'll get them. I wanted to first, so how does everything going for everybody? I mean, well, we just talked on just last Friday, so I don't imagine there's too much news since then. Let me go over a couple of things regarding what we're going to be doing tonight. For a few minutes for introduction, and then I have a couple of quiz questions to stimulate some discussion. And then I have two cases that we'll do one at a time. I'll present the case. And in both of these cases, they are built on real people, real cases that I've encountered in my primary care. So I want you to treat this with the level of confidentiality you would treat as any other patient. I'm not going to give you names. I'm not going to give you identifying information that you could identify them. However, if you were to discuss this out in the world, somebody might hear it and think they know that person. So this is, to be just discussed within our group, these cases. We'll get to that a little later. And as Mike said, feedback from last year, going over what trainees said they really enjoyed the breakout session time, did not generally find when you come back from breakout and each group reports back what they talked about, that was not so enriching. And in fact, it kind of felt like people were repeating themselves. So I won't spend a lot of time on that. But one thing that the evaluation said last year is they were wishing I gave a little feedback on what happened to the kids later. So I'll try to give a little bit more real world information about them. Before we move on, wanted to ask you a little bit about some of the get your feedback now on some of the assignments, some of the resources in the module. What did you think of the AAP course? Leo liked it. Anybody have any comment?
Hi, Erin speaking.
Yeah.
Hi. I am new to researching autism spectrum, and as I was listening and watching, I couldn't help but wonder, like our module goes through, is the data from DSM-5 from a very specific population? Like the typical is younger white males. And I'm just wondering if DSM-5's diagnostic criteria stems from that population and just how the field is going to go forward in potential diagnostic criteria, knowing, the more information that we do now.
I mean, I think you're making a point more than I don't have an answer to that, except that I think that the research largely has been done on white populations and Northern European and American populations, and mostly boys being diagnosed. And there is a question of, that 4-to-1 ratio. Does that really reflect the ratio, or is that because of differing presentations, and we may be either overdiagnosing in boys or underdiagnosing in girls? I hope that the research is going to help address those questions and have a more diverse population. That's a challenge. And it also is, as we change the criteria, one of the big challenges then is looking historically, is the prevalence going up or going down, or what's the prevalence? Don't you get the question all the time when people know that you're working on autism? So what is this? Is it why is there so much more? Why is there so much more? And we really don't know if the prevalence has gone up or if it's merely a matter of more diagnoses. So anyway, I'm dancing around it. I don't have an answer for you, but I think that's a very, very important point. So how about some of the videos in there? There was a short one about primary care and late recognition, another about care maps, and then one about disparities and about ACEs. Thoughts on those videos? Just wanted to get your feedback now.
Hi, Jane. Jason here.
Yes.
Hi. Actually, in terms of the care maps, I thought that was I'm a very visual person, and I thought that was just really fascinating to see the amount that these families have to sort through. Mm-hmm. And I think at one point, you're not really sure how it deals with the care maps. Don't necessarily directly talk about equity, but I would say just looking at that visual and seeing what they have to go through, you can see how a lot of these people who don't have the access to a lot of these services or the know-how to access these services do fall through the cracks. And we see what we saw in the other video in terms of these disparities. So I think it's an amazing illustration on how there is a huge gap in the equity among people with autism, number one, but then especially people of various races with autism.
That's nice for me to hear that it's useful. That's good. I mean, because that's why we have it there, to stimulate that kind of thought and understanding. Okay. I think that Choma Torres, who is was a MyLend trainee, and now she's faculty in developmental behavioral pediatrics. What I have learned from her about the disparities, the differences, the later diagnosis, I just think that's incredibly important information. You kind of know that intuitively, but to see the numbers, it's really important. Okay, now then there's the journal reflection, and I think 4 of you have done that. There's a short journal reflection. Did everybody see that assignment? Okay, and the reason for a reflection, and I know it often feels like busy work to do a reflection, but often having to either write something down or record a little video clip forces you to think it through. And that's what that's about. It's not to, don't need a major treatise on it, but just to kind of think it through. And the topic is really, what's the interplay between ACEs and neurodevelopmental disabilities? And we will learn a lot more about ACEs at one of the later face-to-face meetings in the spring. Don't we have a couple of our, Mike, I think we have a pretty intensive conversation about ACEs.
Yeah, Candace Lee, who joins us.
Yeah. So this is just a little introduction that we got here today. Just to circle back with you all before we get going, because at the end we always run out of time. On the Developmental Disabilities Conference, I had several people have expressed interest. Jenny Mendez and Margaret Greenwald plan to do the interprofessional practice. Lauren Wiley is putting together something on sign language for medical professionals. And then Alasia has expressed interest in doing something, and Leo has, but I don't have a topic yet. And Julie is going to do something on perinatal depression and breastfeeding infants with special needs, kind of building on what she did for her family resource. Leo wants to say something. Leo, please.
I just wanted to say, is it okay if I email you later on
Sure.
what
Yeah.
my plans are on that?
Yep. And
Thank
if
you.
others do, if anyone else does, has something, please do send me an email.
Okay.
Okay.
Thank you.
Yeah, sure. So I want to start with a little quiz, and Mike's going to set it up for us with just two quiz questions. And these are the kinds of questions that don't really have one right answer, but are constructed to stimulate a little conversation about some key points.
Everybody see that one, the first one?
Okay, very good. All right. So I appreciate those of you that took a little longer to answer. This is a real world kind of situation. This has happened to me in primary care clinic where with a bilingual family, and you may have an interpreter in clinic, but it's kind of awkward, or you more likely have an interpreter over the phone, or if they're bilingual and they speak English, you're doing it in English, but the English may not be, it's not a first language. So what do you do? So by the book, with this many fails on the MChat, you would go ahead and do exactly as 62% said here, refer to early on audiology and CMH. However, the responses on the MChat may not really reflect what the child can do. I mean, I would have some concerns. So if I could get an interpreter to do with the MChat, there are the follow-up questions on the MChat. I think I've talked a little bit in the ASD module to get a little bit more in depth to be sure that people were in fact answering the question, that they were understanding the question and it truly reflected the child's behavior. So between the refer or the get an interpreter to learn more would be more correct and reassuring the parents. This is because it's a bilingual family. We often, and in the past, it used to be kind of standard advice. Oh, if it's bilingual, if their child is hearing two languages at home, they're going to be delayed. And that has been found not to be true, or at least we shouldn't assume that bilingual status is responsible for a child not meeting the typical milestones. Typically, children in bilingual households, their language development is right on the mark with children in a monolingual household. It may be harder to measure because they may have a number of their words in the other language. So they may have a total of 50 words, but 20 are in their Hmong language and 30 are in English. And the parents may not be understanding the English ones because they're not said very well. 2-year-olds don't articulate very well. But we need to be careful not to under refer because of a bilingual background. And then those of you that are in speech and language or audiology probably know there's a pretty good literature about being exposed to two languages in general is very good for brain development and development overall. Okay, thanks. Anybody have any comments on that? Leo?
I was just gonna comment that I relate a lot to this story because, like I said last time, I'm bilingual. I speak English and Spanish. For me, it took about a year for me to like pick up English because English wasn't my first language. It was Spanish, but I never had any trouble. Like, I know that there's some kids that mix words,
Mm-hmm.
but for me, it took about a year to kind of process everything and kind of understand. Okay, this is a different. I still, till this day, like I still get stuck on a word or two, such in English and Spanish, but it doesn't happen often. So, yeah, the brain does take a while to process that type of stuff.
But it does, yeah. Thank
Yeah.
you.
Thank you.
Okay, let's go to question number 2, Mike. All right. So 93% of you think you need to gather a little more information to complete the form for an autism evaluation. That makes sense. You know, I mean, you can get more information to see if it works. It certainly does. I mean, I think you wouldn't want to miss it. And though I think it's probably one who said early adverse experience explain his behaviors, true. On the other hand, you wouldn't want to miss autism because of that, because a child can have both. Children can have the early adverse experiences, and it can be difficult to sort out. His meltdown certainly could be that. But his mother is concerned, so we need to get more information there. And I'm glad you all know that he's not too old to be tested. And just because he can speak in sentences does not mean exclude the possibility of autism. Okay. All right, we're moving right along. I came up with a little timeline and we're moving right along with it very nicely. So this is good. I'm going to start by telling you of a case of a child that I saw in a primary care clinic several years ago. And this was working at the county health department clinic. I saw a 27-month-old. I'll give you some details here. You can jot down some of the information. And then you'll go into breakout rooms. We'll do 3 rooms, right, Mike? Do we have enough people for 3?
Yeah, I have the three rooms set. Did you want me to show the sheet with the details while you're talking, or no?
I think they've seen it on it wouldn't hurt. That would be fine to show the details of what questions to be thinking about. And and you may have already seen them if you looked on Zoom. They're posted there.
Yeah, and I dropped it in the chat here too.
Okay, good, thanks. All right, so this is a 27-month-old boy who has been brought to clinic by his mother for well, was scheduled for a well child visit because he hasn't been seen in clinic since he was 2 months old. He came for his 2-month checkup and he hasn't been seen since then. So he's kind of dropped off the radar for this clinic. And when he's checked in, the medical assistant, or actually the day before, the nurse looks at the MICR, the state's immunization record, and his only immunizations he received was he got a hepatitis B shot when he was in the newborn nursery, and he got his 2-month shots and none since, suggesting that he truly hasn't had primary care since he was 2 months old. His mother is bringing him in because he's not talking. So she started getting worried just a couple of months ago. She started getting worried and asked about, have you been to other primary care, or maybe you've been out of state and got his care elsewhere and we just don't know it. She said, no, she hasn't taken him to the doctor because he's never been really very sick. Occasionally he's had a cough or a cold and she's gone to urgent care. So he truly hasn't been seen for 2 years. And he's been well from her perspective. So she started getting worried about 2 months ago, when he just not long after his second birthday, and she called early on. She learned of early on because her aunt has a daycare and this mother volunteers there sometimes, and learned of early on from her aunt. She's also noticed that when she's at the daycare, other children her son's age seem to talk more. She says he seems to hear pretty well. He responds to sounds, and she hasn't had any concern about his hearing. She also got worried because she has another child. She has a baby girl who's now 9 months old, who is now actually making more intelligible sounds, talking more than this two-year-old. So her radar went up, and she learned from a friend that if you have a child with a developmental delay or a developmental problem, you might be able to get Social Security. So she comes to clinic because he's not talking, and she's hoping that we can help her apply for Social Security to get disability benefits because of his delay. She describes that he cries all day. She says he falls out worse than a temper tantrum. He'll get upset and he can't express his thoughts, or at least that's his interpretation. He's trying to express himself, and he will kick and scream and cry. His tantrums last about 5 minutes. When he has been seen by the early on coordinator, who on her observations thought he should be evaluated for autism. He sleeps all right, but his mother says he bangs his head until he goes to sleep. And if he wakes in the night, he'll bang his head again. And whenever he's upset, he will bang his head. She has the impression that he's been banging his head from when he could first lift his head off of the mattress. He'll get mad and he'll hurt himself. He doesn't take change well, she reports, and he doesn't like to be around other children. She says he eats pretty well. He won't eat with a spoon, and he can't drink with a cup on his own at this point. In terms of his past history, the pregnancy was fine. She didn't have any trouble. He was born about 1.5 weeks after his due date and was induced. There were no problems as a newborn, though he was a bit of a slow eater at first, and he was a little behind in his motor development. He was a little late crawling and a little late walking. No history of head injury, no histories of having a seizure. In terms of services, she has gotten some resources from WIC. That's Women, Infants, and Children for nutritional services. She says he doesn't have any trouble peeing or pooping, and he is still in diapers. He's never had any surgeries, no significant histories there. What we do, and I'm talking medical language here. I'm bringing the perspective of the pediatrician, and you folks, we're going to discuss this using your language from your discipline and interpreting it for, trying to use plain English to interpret it for the others. He doesn't take any medicines. He's been really quite healthy. And in terms of what we call a review of systems, going down a lot of different issues, it's just that he's been irritable. He's not talking. He has a little bit of a runny nose that started yesterday. And he has these temper tantrums. On physical examination, his weight is, his height is 2 feet 8 inches, which is at about the second percentile for age. In other words, of 127-month-old boys in a room, line them up from shortest to tallest, he would be second from the shortest. His weight is 23 pounds, and he's also at the second percentile there. So again, his weight, he's one of the lightest kids, and he's pretty well proportioned. His height and his weight match. So he's not skinny, he's not fat, he's just small for his age. Physical examination, he's moving a lot, kind of hard to examine, but that's not unusual, of course, for a 27-month-old. And it's essentially a normal examination. He doesn't, except for he will not interact with the examiner, with me, and I can't understand anything he says. And it's not even really clear babbling, you know, it doesn't, toddler babbling when you can't understand the words often sounds like language. You know, you can hear the cadence, and it's even different in different languages. He doesn't have that, have that kind of babbling. On exam, the other thing on his skin exam, he has one birthmark, which is a little bit lighter, hypopigmented, we call it, a little bit lighter, but it's just one lighter on his side. We do in clinic, as people come in, the parent fills out 2 questionnaires that you became familiar with on the AAP course. One is the ASQ 3, which is looking across development in 6 domains. And he does, from the mother's responses, he's delayed in language and in fine motor and in his social skills. He's okay in his gross motor skills. MChat is done, and he has 11 fails on the MChat. So MChat is very strongly suggestive of autism. So just to start there, I'm going to give you a little bit more information and then let you go and discuss this case using this kind of thinking about what is typical, answering, kind of using, you don't have to go down and check off each of these questions. These are to help guide you a little bit. So in my to-do list, I made some referrals. You can discuss what those referrals would be. And I called his early on coordinator. This I did, of course, after the visit. She responded right away. And I'll get you a little bit of information on that. When I talked to his early on coordinator, she has a lot of concerns about his development. She said watching him, and she's pretty experienced, she said she had high concern, high suspicion of autism. She was also very concerned about the social situation. This is a single mom who is clearly living close to the edge in terms of finances. And because of the living situation, where she's living, and what she learned from neighbors and kind of traffic around the home, the early on coordinator thinks that the mother is probably supporting herself as a sex worker. So that adds another dimension of complication of how do we support her. So questions for me before you head off into your small group? All right, so let's go into small group. Again, you'll be looking at this just as who you are, wearing yours. And if any faculty or mentors join the group, I'd like to be put in a group, Mike. I'd like us to be, be on mute and basically kind of listening. And I think, let the trainees can run it. And if they have a question, they can specifically direct to the faculty, that's fine. But let's just be the fly on the wall while let everybody else run their discussion. And we'll come back together at 6:20. Okay, well, I hope the other groups had as rich a discussion as we had in our group. Really good discussion about this. Based on feedback from last year, I'm not going to ask everybody to kind of tell us what they came up with, what they thought. I thought instead, I will go ahead and give you a little bit of what I thought as the doctor and where we went from there and what happened. Okay. So my assessment was that this is a 27-month-old with lots of signs and symptoms. His history and what I'm seeing in clinic really pointing to a very likely diagnosis of autism spectrum disorder. Also in what we would in medical terminology call a high-risk social situation with a single mother, and then learning from the coordinator that mother is having trouble making ends meet, and also the fact that he really hasn't had any of his health care for 2 years. And of course, as physicians, we see health care as paramount, and anybody that doesn't come to see us, they've got something wrong with them, right? Now, from her point of view, he was doing okay, but high risk social situation, high likelihood of autism, clearly has speech and language delay and some behavioral issues. So we made a referral, 3 referrals. One was to early on. He's already connected with early on, but we connected with that to reinforce the early on. And then a referral to community mental health for an autism evaluation. And community mental health can do autism evaluations for children who are covered by Medicaid. They have to be referred by a physician, and the CMH team has a psychologist and a speech pathologist, and they do a speech and language evaluation and an ADOS, the specific evaluation for autism. And they don't have a physician on the team. They rely on the primary care doctor who makes the referral to do the medical evaluation, to look to see, is there something else going on? Is there an ear infection? Is there a history of seizures? Is there a history of prematurity? Is there something that can help explain what's going on? So we made those referrals. And he was to come back in a month for his next set of immunizations because he's really delayed in his immunizations. So we got him on the schedule for an accelerated catch-up on immunizations. And he was lost to follow-up. Didn't come. Call the family, can't get through. Send letters, don't get through. Talk to the early on coordinator who was still seeing him and encouraged her mother to bring him in. She didn't keep the appointment with CMH. We're connected with CMH working at the county. We're right, we can look at the work. We have a behavioral health consultant in clinic who can look to see, does somebody have an appointment? Did they keep their appointment? Didn't keep their appointment. Did keep in touch with the early on worker for about 6 months. And then mother moved and there was no forwarding address and lost a follow-up. I learned from the early on person about 15 months later. He had resurfaced in another county, and he had been receiving services and had been placed in foster care. I don't know the circumstances of what happened with the family. He was placed in foster care and he blossomed. He was then reevaluated. He was evaluated for autism after he'd been in foster care for a while. Many of the behaviors that suggested autism had disappeared. He still had a language delay, but he was catching up. And it was really at that point he did not meet criteria for an autism diagnosis. So this is a case where probably this ACEs were responsible for many of his delays and behaviors, and clouded the picture. So very complex case, but I hope it was a good case for you to kind of go through what are the expected behaviors at this age, what are you looking for, and what specialties or what services do you need? Any comments before we move on to another case? So, okay, I hope it was illustrative and let you draw on some of the things you've been learning here as well as what you've learned before. So I'm going to go to an older child. This is also a real case. So again, I don't want, talking about this outside because, somebody might overhear you and think you were talking about somebody they know. It might not have anybody, not this child, but start to kind of think about, oh, maybe they're talking about us or whatever. So treat both of these with confidentiality. So this is an older child, an 11-year-old. I'm going to call him Jason. That's not his real name, but I'm going to call him Jason just to be able to use a name. So Jason came into my primary care clinic. I knew him well. I had taken care of him since he was a toddler. His mother brought him in because he had bruises on his body and on his face. Someone at his school had called Children's Protective Services because they saw bruises on his face, and then when they checked under his shirt, they saw bruises on his shoulder. So he had bruises he had bruises on the right side of his face and on his left shoulder. So bruises on the right side and his left shoulder. The CPS took him to the emergency room for an evaluation. They ran some blood tests, kind of looking for, does he have a bleeding disorder or something? And they got an x-ray of his shoulder and of his ribs, and everything looked okay. They weren't quite sure what was going on, that they didn't know him. And they could see that he was not communicating. He's deaf and has no oral skills. And they said, take him to your primary care for the next evaluation. And she came in the next day. They told his mother to bring him to me. So I know him well. He is profoundly deaf. He has a cochlear implant, which was placed quite a few years ago, but he rarely connects it. He does not seem to like it. He shows his dislike by pulling the connection off and by banging his head when it's on. So he's rarely connected to his cochlear implant. He attends a center-based program. That's a school for children with special needs. So he's not in a community general ed classroom at all. And it's with many of the children there have multiple special needs. They have significant health and developmental challenges. He gets all of his services at school. So whatever he gets, it's at school, in his classroom, and provided they have OT and PT and communication specialists there. He was diagnosed with autism when he was about 6 years old. Prior to that, his behaviors were attributed to his developmental delays and his deafness. ABA has been recommended, but his parents do not have a car and they can't transport him to treatments. They really can't take him, other than they can get him on the school bus and they can get him off the school bus. They just don't have the means to take him elsewhere. Nutrition has been an issue for Jason throughout his life. He was difficult to feed as a baby, didn't gain weight as expected, and then did some catch-up weight gain. His height and weight and his BMI are all around the 50th percentile for an 11-year-old now. But he continues to be a very, very picky eater. In fact, he won't eat any solid or semi-solid foods, and he will only drink liquids and only out of a baby bottle. He won't drink out of a cup. His parents have tried to get him to drink from a cup and have offered him foods, but he refuses. He really lives on strawberry Pediasure. Pediasure is a child's version of something like Ensure, so it has all the vitamins and minerals and nutrients that the body needs. He is very persistent in his refusal to drink from a cup or eat any food. 2 years ago, one of his teachers really thought that he could, there was no reason why he shouldn't drink from a cup and eat food, and that perhaps his parents were enabling this behavior and kind of spoiling him at home and not really trying hard enough. So she refused to let him have a cup, to have a bottle in the classroom. And it reached the point that he ended up in the emergency room getting IV fluids because he got dehydrated. He was that persistent to put himself, dehydrated. He has a very strong will. He lives with both of his parents. They struggle economically. This seems to be a theme for me this evening. They were evicted from their home because it was it was against code. It wasn't, they were living in a trailer park, and they had their own, they were renting in a trailer park, and it was closed because of such unsafe facilities. So they're now staying with a relative, his mother's sister, and her sister's family, and the three of them, mother, father, and Jason, sleep in the living room. They have mattresses on the floor. So they're really stressed, and this may sound like I'm making it up, but I'm not making it up. And unfortunately, this is, it's not common, but it's not rare. Physical examination. He's looks well nourished, not fat, not thin. He looks fine. We are unable to get any vital signs because he really won't get on the scale and can't take a blood pressure, and he's moving around the room constantly, kind of making grunting noises, but not making any intelligible sounds. He seems agitated, and he's constantly going like this. And then, other than I'm not able to do too thorough an exam, I do my best. On examination, he does have bruises on the right side of his face and on his left shoulder. No bruises on his right side, no bruises anywhere else on his body. So we've got some questions for you here. We know he has autism. He's been diagnosed with autism. We know he's deaf. We know he's, one of the things you might want to talk about is what is this with the cochlear implant and a kid with autism? How does that go down? If you have an audiologist in the group, you can talk about that. Add that to the list of questions. And then we'll go over, the rest. What do you think is going on? And, there are several issues I brought up. How would you prioritize those? And where do you go from here? You might want to talk about his school setting. We've had a lot of talk about inclusion versus he's not in an inclusive environment. Would he be better off in an inclusive environment? And if you can come up with a care map, at least a care map in your head for him of who's involved in his life. So it's 6:35. Let's come back together. Let's come back maybe at about 15 minutes at 6:50. Does that sound all right? And then we can, because I want to wrap up by 7. Okay, I was in another group, and again, I thought a very rich discussion and sorting it out. And to give you the follow-up on this, it's just like little baby steps. This child was not then getting the services he needed for a variety of reasons. They did not have adequate services at the school. We're not providing, at that time, we're not providing ABA. And one of the comments in my group was that, boy, he was diagnosed with autism when he was 6, and he's now 11. In 5 years, there's been no progress. There's a problem here, a big problem. My assessment was that this was his bruising was due to self-injurious behavior, not due to abuse. So we did not go further of, looking to see who might be hitting him or what might be going on. I mean, I saw it happening in clinic, exactly what was happening in clinic. And we tried to do a little bit more wraparound and provide more services for the family, but mostly to try to do them at school because it was so hard for them to get him anywhere else. I mean, they really felt very limited. I don't have follow-up in the last few years. I don't know if he ever was able to tolerate the cochlear implant and learn to communicate more effectively. Our sense was that it probably was a really irritating noise in his head. And he didn't know how to interpret that. He wasn't able to, without getting used to it and learning how to use it, it didn't help him understand the world around him. It was just a really annoying noise in his head was the best that we could interpret. So I don't have long-term follow-up on him. We just kind of kept trying to provide the services we could medically. School tried to provide the services that they could, and the family continued to do their best. But this is a child who, with more optimal services, I think if he had been diagnosed with autism earlier and getting ABA, he might have been in a very different very different situation. And I don't know where he must be, about 20 years old now, and I don't know where he is. Unfortunately, lost contact with the family. So that's all I had on my kind of feedback on that. What are your thoughts? Any parting thoughts? I don't need a report out from each group, but things, aha moments or things that you want to go and learn more about after having this discussion, and as well as the various course materials. Any thoughts?
I thought the training was beneficial, and it was good to watch through those resources.
Good. Yeah. The training is intended for pediatricians, but it seems to me that it's done in a way that can be useful to people from a variety of backgrounds, including self-advocates and family members. Does that seem?
I mean, I thought all the trainings and the videos, all the resources provided were helpful to me from an ABA perspective, kind of just to solidify some things I already knew and show me some stats that I wasn't fully aware of.
Okay.
The ACEs thing, I think, was really a good addition to that segment as well.
Oh, good. It's pretty short, but it's good, I think. It really hits the high points.
I had taken a full class and it was an ACEs class, essentially a childhood maltreatment and trauma. And I thought the video did a really good job at concisely describing the ACEs. So
One thing that's remarkable about the ACEs and the background there is the knowledge about ACEs. It's been available for a number of years, and it's been ignored. It's beginning to be incorporated into clinical practice and in schools and an understanding. But there's an incredible knowledge base there from that original study at Kaiser that has just been ignored. And those of you that haven't had a chance, do your little, reflection about ACEs and interplay between ACEs and neurodevelopmental disabilities. You might not get it, by the book. You're supposed to do it today, but I will understand if you're watching election results instead.
And Jane, I apologize. I had it on there to complete it by December 1st, so that might have been. That was my fault. Yeah,
Oh.
I just noticed it in Canvas. So.
Okay, well then complete it by December 1st. That's fine. That's fine. That's fine.
I think that was the leftover from last year because we flipped those modules this year.
Right.
So,
That's
yeah.
right. We didn't get the date changed. And I didn't pick that up when I was reading the module. Okay, so nobody's late. That's fine. And that means I don't have to read them this week. That's okay with me.
I put the link for the AAP course directly in the chat here for those who are looking for it, but it is listed on our clinical page. And I also misspoke. If you could, and some of you have already done this, when you do complete it, you'll get a certificate. You can download it or do a screenshot. And if you could, just send that to Jane and myself, just so I can. And make sure you record those hours in your tracking sheet. It takes a minute to finish those. So that's good clinical hours.
If you already did it and you didn't capture a screenshot, just send a message you did it.
Yeah.
That's fine too.
We trust you all.
Yeah, we trust you all. I don't need to see the screenshot. Sometimes a screenshot can be a bit of a challenge. Okay, well, I am ready to wrap up at 6:58 unless somebody has any other comments. Okay.
Right.
These are long days, aren't they? It's a long day. 5:30 to 7 is a long day. Okay, well, have a good evening, and we'll be in touch again soon. Thanks,
Absolutely.
everybody.
Yep. And look for the
Thanks,
evaluation. Everybody. Evaluation will be hitting your inbox in like 2 minutes. So please.
We use
that
information. We really, really use it.
Yeah, so please take a few minutes and complete that when you can. I appreciate it.
Yeah.
All right.
Okay.
Everybody
Thanks a
have a
lot.
good night. Don't watch too much news. Don't watch
Yeah.
too much news.
Bye-bye.
Bye-bye. See y'all.
Bye-bye.